Is it better?
Yeah. Yes, it's very good. Thank you.
So anybody who can describe this? No volunteers, is it? Shall I pick somebody?
Johnsy, can you answer?
Sean?
Hello.
Oh, yeah, go on then.
Yes.
Sure.
So on the X-ray of the lateral view of the spine, the intervertebral joint space seems to be equal in each level, and seems to be a minimal anterior column compression at the central.
Okay. Yeah. So you start describing the X-ray. So where is that disturbance coming from? Is it me? Disturbance? No.
No,
Okay.
sir.
Yeah. When you start describing the X-ray, you said lateral view. Lateral view of which part of the spine? Is it thoracic, cervical? Yeah, it's more likely thoracic spine.
Yes, sir.
Yeah, thoracolumbar. And you do have a AP X-ray as well there. Okay.
Yes, sir.
Yeah. So obviously you started describing about intervertebral disc space. So is that important in describing the intervertebral disc space in the X-ray? Does it make any difference to what you do? So in the X-ray, when you say intervertebral disc space, is it important? Does it give any information to you?
So it could signify an intervertebral disc prolapse.
Yeah. So intervertebral disc prolapse. Do you look on the X-ray or do you look on the scan? Usually MRI scan. Describing in the X-ray, it's probably better to stick to the bony anatomy rather than. Yeah.
Okay.
So you rightly said there is anterior wedging of one of the vertebrae. We don't know which level it is. And is there anything else you can see on the lateral view?
So even the spinous process at that level seems to be destroyed, sir.
Not destroyed. Destroyed means like it is like it's a lytic process. You can't see it properly. Yeah. So other thing you can see is that if can you see my arm?
Yes.
The foramen there and the foramen here is wider when you compare to. Yeah. So on the AP view, can you see anything?
And there is lysis of the spinous process of that vertebra.
Why do you say lysis? When you say lysis, what does it indicate? Like a destructive process, like a pathology, like a tumor. Do you see any signs of the tumor there? It's an empty space there, isn't it?
Yes, okay.
Yeah. So you can't say lysis in the situation like that because you can't see the spinous process. It's not lysis. There is no lytic lesion or anything like that. But the spinous distance between the spinous process above and below is increased, definitely. So what do you think it is? If I say this is a 25-year-old man who came off the motorbike, any idea?
Yeah.
What would do that? So it is anterior wedging of your vertebra, along with the increased interspinous space, increased vertebral foramen space, and the spinous process are away in like distracted too much. So what could be this? More likely an injury which is going through the disc, going through the posterior elements, and going between the interspinous space as well. So it's a chance fracture, they call it. Fracture going across the spinal column. Yeah. So it is a soft tissue chance fracture. So basically, you damage the whole 3 columns of your spine. So anterior, the intervertebral disc space, along with the end plate, and you damage the interspinous ligament and supraspinous ligament as well. What do you do for a 25-year-old man came into accident emergency with this injury?
We stabilize the fracture with screws and rods.
Yeah. So before that, when you assess these patients, what do you have to assess? What do you want?
Assess the neurological and features, the motor and sensory.
So when you answer in the exam, it's probably better if I said 25-year-old came off motorbike. So you need to exclude any other injuries, ABC, other injuries. After that, for a spinal injury, you examine the patient, examine neurologically, and notice any neurological deficit. Also look for any whether his blood is working or not, very unassuming. So these are important things in a spinal fracture. Yeah. So if there is a spinal cord injury, you can't go straight to the theater. You just assess the patient, record everything before taking the patient to the theater. So before taking the patient to the theater, what else you want to see? So do you have any other investigations you need to do?
So we'll do an MRI of that region to record the soft tissue element, the ligaments and the.
Yeah. So the MRI scan will give you the information about soft tissue elements, which I'm looking at the X-ray, you can see that it is completely gone. Apart from that, what else the MRI scan will tell you? In the spinal injury,
Spinal cord injuries.
yeah, in the spinal injury, there is a likely chance that you have other injuries as well, 20% chance. So you could pick up other injuries to other vertebra. And you can also look if there is any damage to spinal cord or any hematoma in the spinal canal. So that's the MRI is going to go. Any other investigations you want to see? You want to do? I would get a CT scan as well. So if you get a CT scan, it will give you the information about the bony anatomy. So if you want to fix them, more likely you need to fix them because they're unstable. So you get a CT scan as well to see the bony anatomy. Anybody who knows what this is? This is the same patient. Is there anything abnormal in this X-ray, in this CT scan? This is a CT scan of the same vertebra. You describe me what you are seeing here. So this is the vertebral body. Yeah. This is the transverse process. And what is this part?
So by spina bifida, sir?
Spina bifida, usually you see the spina bifida here, like spinous process here, isn't it? This is the facet joint, isn't it?
Yes.
Yeah, that's the pedicle. This is the facet joint, and that is the canal. So the facet joint is empty here. So there is the other facet which is supposed to be articulating here is not there. Yeah. You don't see this unless you're like taking the bone out, taking the CT scan of the bone. Otherwise, you will have a facet here articulating with this, which is not there, which means that the patient, when he had this, he completely subluxated his facet joint. So this is called empty facet sign. So if you see that on the CT scan, that means that it is unstable, and the joint is dislocated, subluxated. Okay. So this is unstable fracture. That is the injury. So you can see that there is no damage to the cord itself, but you can see a lot of edema here. There's a star sequence, I think, and there is a lot of edema here on the posterior elements. And this is where it's gone through the disc. Possibly superior end plate fracture there. So he's neurologically intact. He's fit and well. No other injuries. What will be the plan for this man? What do you do? Get him up, mobilized, or do you do any operations to stabilize?
And chance fracture, it's better to do a surgical intervention and stabilize.
Yeah. So how do you stabilize them?
So we go through.
So to stabilize the spinal fracture, you can stabilize from the front, go in the front here and put a cage here and put screws and rods, the screws to stabilize with a plate. You can go from the back, put a screw through the pedicle. So use this pedicle and this pedicle. So 2 screws above, 2 screws below, and put a rod across to hold it together. Or sometimes if there is a lot of damage in between, so you might do the front and back as well. Yeah. So for this, is young man, the anteriorly is not that much destroyed. So we can use the pedicle screws from the back and stabilize it. Yeah. So if you go there, that's how it is done. So you put the screws above, put the screws below, connect the rod. So you compress the fracture and you stabilize it, and this lesion will heal if you leave it like that. Yeah. Any questions? Anything you want to ask here? So when you go to the exam, what you need to read is these ones. So in a fracture situation, just don't go directly to I will operate. Start with the examination of the patient, neurological level. So if there is any neurology, just document it. And sometimes if there is a progressive neurology, though he presented with some weakness, but is getting worse, that means that he needs an urgent operation. Also, read about spinal shock. What is spinal shock and how you diagnose it in the spinal cord injury. And the role of steroids is a controversial thing. If anybody in the exam is a spinal surgeon, can pick it up. So read about role of the steroids as well. So what I haven't gone through here is because you haven't given me all the information what I needed. So I didn't go up to classification, but the classification of these fractures is based on mechanism of injury, the Dennis classification, 3-column injury or 2 columns, or AVO classification. The current one which most people are using is the TLIC scoring system. It is based on the mechanism of injury, neurological deficit, MRI scan and everything. And you score from 1 to 3 in each, and you can look at it. And that is the more useful one for whether you stabilize them or whether you can treat them conservatively and stabilize them. How do you stabilize anterior, posterior? So that is one useful system classification. Management, we discussed whether give them bed rest, braces. Usually not necessary these days, where we can stabilize them with the screws. So most patients, if they're unstable, get an operation. Brace, there is no evidence clinically or in the literature where the brace will stabilize any fracture. So braces, when they give it only for a pain relief. It doesn't help in stabilizing it. If it is unstable fracture, it needs operation. So surgery, as I said, either anterior, posterior, combined, depending on where the fracture is, how bad the anterior column injury, whether it is only anterior or posterior column. So it all depends on how unstable it is. Okay, any questions? Anything you want to ask anybody?
Sir, regarding the use of braces in fracture, sir. Regarding the use of braces in spine fracture, sir.
Yeah.
You said that it is only for pain relief. So is it not necessary to give any brace like preoperatively?
Yeah, so that is the change of the concept now, because if it is going to be stable, it is going to be stable even with the brace, even without brace. So your body must, has enough protective mechanism not to make it unstable. So if it is unstable fracture, fix it. So there is no need to brace. If it is a stable fracture, brace is not going to do anything. It's not going to stabilize the whole spine. So there is no evidence to say that braces will help in preventing any collapse. Many people are coming up with the braces. Even if you give, sometimes we give it only for pain relief. You need to wear it all the time. So that is the new way of managing. Before we used to give that the anterior hyperextension brace and all these braces, but there is no evidence that it prevents any collapse of the vertebra. It makes it helps in clinically make a lot of difference. Anything else? So the classification, we could go through the classification, but it's probably better to read. There are so many things to read, especially a TLIC scoring system is an important one. So next one, who is going to take the next? Okay. Any volunteer? So your 14-year-old girl presented to your presented to the clinic with a deformity here in back. No pain, just a deformity noticed a year ago. So what do you see and how you describe this? I think I need to pick up somebody, Balu.
Yes, sir. Johnsy, can you volunteer? Johnsy, are you there? Dr.
Yes, sir.
John.
So we can see a 14-year-old girl standing erect, and you can see thoracic curve to the right, convexity to the right.
Yeah.
With a prominent scapula
Yeah.
on more on the right, and pelvis is tilted upwards on the left.
Yeah.
I'm not able to appreciate any wasting.
Yeah. What else you can notice apart from pelvic tilt, scapular prominence? That's a very good point. Other thing which you look at, shoulder heights, whether the shoulders are in.
The left shoulder appears to be at a higher level.
Yeah.
Yeah.
Okay. So when she comes to clinic, what are the things we are going to look into her? So what do you do? This is a scoliotic curve, isn't it? Like scoliosis of. So how do you examine them? What are the things which you are going to look and the history?
Mainly for a scoliosis patient, I'll ask them when both the patient and parents, I'll be asking when they started noticing the deformity, for how long it has been, whether it was there since childhood or whether it is now since she is 14 years old, whether it is in the last 2 to 3 years, and I'll ask her when was her menarche.
Yeah. So what are you differentiating between starting when it, so in the history, when you say when it started, what are you trying to differentiate?
Trying to differentiate if it is a idiopathic adolescent scoliosis or a congenital scoliosis.
Congenital, yeah. Or early onset, late onset, yeah?
Yeah, early onset.
Okay. And what is the importance of menarche? Why do you ask for menarche?
The scoliosis tends to progress up to menarche.
Wouldn't be a progression post menarche.
Post menarche, there's no much progression.
So 2 years after menarche, so your axial skeletal growth, so the spinal growth, after 2 years of your menarche or puberty in boys or puberty in girls, like after 2 years it stops. So you don't achieve any axial growth in the skeleton in your spine. So that is the important thing. So if you see somebody who is 14, she presented to you, she says that her menarche was at 11. So there is unlikely that she's going to be progressing any further, but she hasn't had her periods yet. Then there is likely that in another 2 years' time it's going to get worse. That is the importance of it. Yeah. So clinical examination.
Yes,
What? Yeah, clinical examination. What do you do?
I'll again confirm my inspection findings, sir, with the palpation, and also I'll check for any tender points, tenderness over the spine.
Okay. So is it usually painful?
Usually it is not painful.
Yeah. It is painful. What do you think? So usually in children, sometimes if they have any spinal pain, they can present with a scoliotic curve. So that is completely different. It's a positional. Yeah. It's because of the spasm of the muscles. You see that scoliotic curve. So if it is painful, then it's completely different pathology. Yeah. And what else you look for?
I'll check for any rib hump, sir. I'll ask the patient to. I'll do the Adams test and I'll check for rib hump.
So Adam test is for what is it for? Rib hump, is it?
Structural to differentiate
yes,
between structural and non-structural scoliosis.
Yeah. So the forward bending test is not to differentiate, like not to measure the rib hump. It is to differentiate whether this is getting corrected. If it gets corrected, that means it's a positional. It's not a structural curve. It's a functional. Yeah. So that is what you do. Yeah. So what else you can do to differentiate between the functional curve and the structural curve?
We can also make the patient sit and see.
Yeah. So if you take away if you spare the pelvis, so the functional curve is because your pelvis is not equal, or there is abduction deformity, or there is a leg length equal. So if you make them sit 90 degrees on the pelvis, like if you take the pelvis, square the pelvis, that disappears. So those are the two things you do when you examine them. What else you can look? So you look for kephalar spots.
Dr. Fair.
Yeah. What does it indicate?
Spina bifida.
Neurofibromatosis. Kephalar spots, we check for
neurofibromatosis.
Yeah. And neurological examination to rule out any upper motor neuron signs. Sometimes, even though it is adolescent idiopathic, if they have any upper cervical compression, they can have upper motor neuron and signs. So you look for a complete neurological examination. Yeah. So, yeah, question? Somebody asking something? Anything you want to ask? 2 seconds, guys. I just need to take this one. Hello? Yes, please. Thank you. Hello? Hello? Yeah, Mr. Rao. Yeah. 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 Mm-hmm. Yeah. Yeah. Mm-hmm. Mm-hmm. Yeah. Mm-hmm. 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 Okay, that's fine. So what was the injury on the MRI CT scan? Okay.
Sir, you can unmute yourself, sir. Prabhakar, sir.
Sir, your voice is muted.
Okay. Yeah. So who's going to describe this? Anybody?
Anyone? Anupam?
So this is
Yes, sir.
yeah.
So this is standing X-ray of covering the whole spine, the pelvis, and the pelvis of a skeletally mature person.
Yeah. What you know? What do you call that? It's called scoliogram.
Okay, sir.
AP scoliogram. So anterior-posterior scoliogram. In a girls, we take as a posterior anterior, but you can say AP scoliogram. Yeah.
Okay, sir. Okay. We can see there is a curve of the thoracic spine with the convexity to the right side.
Yeah. And you can't see any congenital abnormalities. Yeah. So you can mention sometimes if there is any fused vertebra or anything like that. And on the lateral view, what do you see here? There is no thoracic kyphosis. So they call it hypokyphosis. So usually in adolescent idiopathic scoliosis, your thoracic kyphosis disappears and you have a less kyphosis in them. Yeah. What else you see in this X-rays in idiopathic scoliosis in girls or any adolescent idiopathic scoliosis?
So we check for the Risser's index.
Yeah, Risser's index. Yeah. So what does it indicate? Do you know what is the index is?
Yes, sir. When there is an ossification of the iliac apophysis.
Yeah.
So here it depicts at stage 4. That means the ossification is completed.
Mm-hmm. So it comes from medial to lateral or lateral to medial?
Lateral to medial, sir.
Okay, the other way around.
Okay.
Yeah. So what do you think this is? It's difficult to see in this X-ray, but it's either 1 or 5, isn't it? So it's either fused or not. Yeah.
Yes, sir. It looks fused.
Yeah. So like in scoliosis, it's a 3-dimensional deformity. Okay. So the things which you need to know about. We're trying to see. Okay. Can you see? Can you read other things? Yeah, on the other side on the screen. You can read this.
Yes, sir, we can.
Yeah, yes.
So important thing is that to look at for apical vertebra. Apical vertebra is the one where it is most rotated vertebra.
Yes, sir.
So our most deformed vertebra. So end vertebra is the one where is most tilted to the. So if you take the apical vertebra, most tilted away from this. Yeah. So you take the upper border of the top vertebra and lower border of the bottom vertebra and draw a line that is called Cobb's angle. Anything more than 10 degrees is called scoliosis. Yeah?
Yes, sir.
The important thing is to know what is the and these X-rays of the same patient. What are they trying to do here?
To see if it's a rigid or non-rigid.
Yeah, so it's basically bending filling. Trying to see whether it's rigid or not, and also whether it is getting corrected and where it is getting corrected. You know what is the importance of it? Why do we do that? So to look at if it is getting balanced here, then you can stop your fixation up there. So that's why we need to look at and bending, which is the one which is not moving. So you can stop their fixation so that you can save more levels. That's why we do the bending planes. And also to find out which is the minor curve, which is the major curve. So the major curve is the greatest one with the greatest Cobb angle, and minor curve is the smaller ones. Yeah. Structural curve is called if it is more than 25 degrees curve, like a fixed curve on the Cobb angle. So treatment wise, do you know the ways we fix them? What are the surgical options here? So you could do anterior surgery, limited fixation, correct from anterior, but it has high morbidity in the sense you have to do a thoracotomy and take all the discs out and correct it. Yeah, and these days with the current implant systems, we can use all the pedicles and use the rods, mostly stainless steel rods, which have more rigid deformity. Basically, you're trying to correct the deformity and fuse them. So you can do anterior and posterior. Sometimes if it is very rigid where we need to correct, then you might have to do anterior. With the current system, it's very, very rare to do that. Before, previously when you used to use the hooks and the Harrington rods, we used to do anterior surgeries. But now with the pedicle screws and the stainless steel rods, mostly we can just do from the posterior. So if you stick onto that, what is this? What scoliosis is this? Anything abnormal here? You do have a curvature, but if you remember idiopathic scoliosis, they do have hypokyphosis. The thoracic kyphosis disappears, but here you have hyperkyphosis. More likely to be a neuromuscular.
Okay.
Yeah, neuromuscular, poly or PP. Yeah. So for the exam, scoliosis is basically definition of your scoliosis. How do you differentiate with functional scoliosis, and also differentiate between the idiopathic, congenital, neuromuscular? The neurological examination is important to note if there is any upper motor neuron sign. So measurements, important ones are the apical vertebra and vertebra. You can define where they are and how you decide them, and then measure the Cobb. This is other concepts where a stable and a stable zone and stable vertebra, which is you can see on the bending films where the vertebra which is not moving. The classification, the most commonly used is the Linke classification. It's very complex. If you are interested, you can know. Other one, which in the exams you might be asked for King-Mo classification. So other type of classification is based on pathology, based on location, and early onset, late onset, juvenile. These are not used at the moment. Mostly is Linke classification. Investigations, we saw them, long film, swelling film, MRI scan. So CT scan, especially in congenital scoliosis, you look for any vertebra and any abnormalities in the vertebral bodies, and sometimes you have fused ribs as well. So we get a CT scan for congenital scoliosis. We discussed about management. So important one is where role of braces and how do you monitor them. Those are the things which might be asked. The brace here also is difficult to manage with a brace in a scoliotic curve because you have to wear this nearly 24 hours a day. And in a kid, especially in a teenage, it's mostly more common in adults. It's difficult to commit them for 24 hours a day or 23 hours a day, except for their daily needs, they can't take it off. When do you monitor them? It's like when, who are the ones you need to keep an eye, who are the ones you can discharge? That based on when they presented, what is the cob angle and how much growth is left in them. So based on that, so if they present early on and there is a lot of growth left, you have to look at how every 6 months take an X-ray and measure. If they're getting worse, then you might plan for surgery. If they are 16, they're already matured and their curvature is only 20 degrees, you probably don't need to monitor. So that is based on how the deformity is and when they present. So the discuss about surgery, anterior, posterior combined, depending on where the curvature is, and this technique of surgeon and how much you want to correct and everything. So anything in scoliosis, guys? Anything you want to ask? No one? Let's go to the next one then.
All right, so sir, there was a doubt regarding neuromuscular monitoring during surgery.
Okay. We do monitor. So if you are correcting the scoliotic curve, any curve in the spine, you do neural monitoring. So there are different types of monitoring, but in scoliosis, we do the cord monitoring. Basically, you put a probe through into the spinal canal, and we monitor from them. But rest of the other methods, we do SSCPs and MEPs. But we have to do monitoring in it.
Yes.
So something, the wake-up test, is that
yeah, that is described in textbooks, but not many people do it now because of the technique of monitoring has improved so much. So very rarely you do that. And the anesthetists don't like it because you have to put the patient back in, like you put the patient to sleep and then wake him up and then put the back. So they don't like it. So many people not like, I haven't seen anybody doing it anytime. It's only described in textbooks.
okay, sir.
We have enough way of monitoring the spinal cord. So this is not, at this moment, it's not necessary.
Prabhakar, can I ask a question?
Yeah.
What are the indications for surgery in an idiopathic scoliosis? Is it purely cosmetic deformity, or what are your indications?
Okay, that's so if this comes down to one is cosmetic, but there's probably not that many people who do that nowadays. Most of it is how is the coronal balance and sagittal balance. If they have more than 40 degrees of curve, so their pelvis is going to be tilted and they're like leaning to one side. So that's going to cause a lot of problems with the gait and with the daily things. So anybody who is more than 40, even at age of 16, 18, 20, we probably advise surgery. And the kids with early onset, they presented at 20 degrees, but they are progressing quickly and they have like 10 years of growth left. For them, we need to do something to correct, like at least maintain their curvature. So main indication is more than 40 degrees of scoliotic curve, you need surgery. Apart from that, rest of the surgeries we do is probably cosmetic. If it is 20, 25, if somebody is doing surgery, it's more cosmetic than anything.
Thanks, Prabhakar.
So what are the long-term complications if the patient ignores it?
So if it is 20, 25 degrees, there's no complication in the sense it's not going to cause any problem. The literature says that even if it gets worse, probably 1 degree a year. So if you are 20 degrees at 20 years, probably by the time you get 60, you may have another like 10 degrees added to that. It's not that much progress. So there's no complication as such from the deformity itself. So to cause any thoracic like capacity decrease or the abdominal problems, it is, they say, more than 90 degrees that causes the like lung problems and abdominal problems. So it is like you can ignore it as much as you can. So it doesn't cause any organic or functional problems apart from cosmetic thing.
Okay, thank you, sir.
Hello, sir.
Yeah.
Sir, one doubt regarding rib hump in scoliosis.
Yeah.
So, is it always mandatory to excise the rib hump, or can we just leave it alone after correction of scoliosis?
Most of the times, because of the current techniques, we derotate the. So the rib hump is because of the rotation of the vertebra. Yeah. So the vertebra is rotated, so that's why your rib is prominent. So most of the times we rotate it, correct the most of the rib hump. Sometimes you have a big curve. Sometimes that is cosmetic. So you need to excise the rib hump. As with depending on the surgeons and the patients, sometimes if it is too problem, do it, but not necessary. This doesn't cause any functional problems or any lung problems or anything like that. So many times it is corrected by your derotation. If it doesn't, if there is a prominence, you can still do it. It's not necessary. It's only cosmetic thing you're doing. Anything else? Okay, next one, who's going to take this? Can I pick somebody?
Go ahead, Prabhakar. You can pick someone. I think no problems.
Yeah. Who is Nikhil? Nikhil? Are you there?
So, this is a plain X-ray of a skeletally mature patient, sir, showing the cervical spine and anteroposterior view, anteroposterior view on the left and lateral view on the right.
Yeah.
On the lateral view, we can see a straightening of there's a loss of the cervical lordosis, and there is straightening of the cervical spine, and there is there is significant disc space narrowing at C4, C5.
Yeah.
Yeah, C4, C5, C6, C5, C6, and C4 and C4, C5, and there is cervical, and there is spondylotic changes.
So this is a 70-year-old man presented with this X-ray, and he's saying that he's losing his balance. His gait is changed, and he's having pins and needles in the upper limbs, both upper limbs. So what are you thinking?
So he's losing his balance, sir. Probably there is a cord changes which is happening, which is suggestive of myelopathy.
Yeah. So when you see them, what do you what do you examine in them clinically?
Upper motor neuron signs, sir, mainly.
Yeah. What are they? So upper motor neuron signs, so power, tone, spasticity, reflexes. Yeah. So what happens to power?
Yes.
Do they get weak or do they get?
Power will be weak, sir.
Usually, you don't see that much of power loss in the cervical myelopathy. So by the time they come to you, you get spastic and they lose their balance and
there is a spasticity and
increased tone. Yeah, and the reflexes. What happens to the reflexes?
Exaggerated reflexes.
Yeah. And what other signs you get to see? Like you try to examine them.
Apart from that, I would elicit the Hoffman sign, sir.
Yeah. Well, how do you do that? You know? Middle finger, flicking of the DIP of the
middle. After stabilizing the proximal interphalangeal joint of the middle finger, I would flick the distal, the tip of the middle finger, and there will be a contraction of the index and thumb.
Yeah. And what other reflexes you look for? Babinski?
Yes, sir.
Babinski. And inverted radial reflexes, right? Yeah. And clonus excited reflex. Okay. What investigations do you do now? Other one we forgot is the Romberg sign. So do you know what is the Romberg sign? So how do you elicit Romberg
sign? So I'll ask the patient to stand erect with the eyes closed and both the feet close to each other. Yes, stand erect with both feet close to each other.
Closed eyes.
And closed eyes, yeah.
So basically,
and if there is a shift to either.
They lose the balance. So even in the history, sometimes they see that when they wake up in the night to go to the loo, they can't, like they're finding it difficult to balance themselves because their position sense is gone, isn't it? So visually there is nothing there. The position sense is gone. That's why. So what does it indicate? You know?
Cerebral ataxia.
Is it cerebral?
No, it is
the difference between cerebral ataxia and
posterior column.
Posterior column involvement. Yeah. So this is completely different from cerebral ataxia. Cerebral ataxia you have incoordination. This is posterior column involvement. So usually you don't have the position sense. So you did the MRI scan. That's the MRI scan. So what does it show?
There is a C6, C7 disc bulge, sir.
Yeah, so basically,
I
think they haven't given the pictures of where the cord damage is. Usually, you see some compression on the cord and myelomalacia changes. Yeah, and most of the times you get a CT of these patients to see if there is any osteophyte. Sometimes your posterior ligament can be ossified and become osteophyte. So if you are approaching, it will tell you about give you an indication which way to approach. If it is all ossified, then it's probably difficult to go from the front. You should go from the back. Okay. Bit of pathology. So this is the spinal cord section. So what are those green ones? What tracts are those?
Spinothalamic, sir.
Which one is which? Spinothalamic or?
The lateral one, I think, is spinothalamic.
So what if I say this is motor? This is a descending.
Corticospinal.
This is corticospinal.
Anterior lateral corticospinal, isn't it? Yeah. The ascending tracts and descending tracts. I think you need to look into this. Descending tracts are the motor tracts, which dorsal column. Basically, this is where you have you heard of the Brown-Sequard syndrome? What is it? What is the Brown-Sequard syndrome?
Hemisection of the spinal cord, sir.
So what happened? Yeah.
There is loss of motor and loss of position function on the side of the injury.
On the side of the injury,
and on the other side, that is the contralateral side, there will be loss of the pain and temperature.
Why is that? Any reason for that to be opposite side?
Because of the crossover fibers.
Crossover, it happens at the middle, isn't it? Yeah.
Spinothalamic tract.
Okay. And the other syndromes in the cervical myelopathy are anterior cord syndrome. So basically, whether it is front or back. So the common one you see is the central cord syndrome. So there's an injury in the central cord. So it's a mixed picture. That's so common. The Brown-Sequard is you don't see that, like it's described, but very rare to see. You can't hemisection the cord without damaging. And there are other syndromes, but most common is central cord syndrome. Yeah. So any questions here? I haven't gone into the theory of like management thing. So in the cervical myelopathy, your approach depends on the surgeon and where the compression is and the patient factors as well. If the compression is mainly anterior, do anterior cervical discectomy or corpectomy, take the vertebra out or do the disc out. But you can do that posterior. Some people do come, but it all depends on so many factors. It's not like straightforward. Oh, this is. Any questions? Anything you want to ask? Okay, let's go to the next one. So somebody describe this. Amrut Raj.
This is again a plain X-ray showing the lateral view of a skeletally mature patient, sir, of the LS spine, lumbosacral spine. There is a pars interarticular defect at L5 vertebra, sir.
Yeah, L5 vertebra. Yeah.
Listhesis. There is listhesis of L5 and
yeah. So what type of spondylolisthesis is this?
Great.
Isthmic type.
Isthmic type. What are the other types?
Dysplastic, degenerative.
Yeah, dysplastic, degenerative. Yeah. Congenital. Post-traumatic. Hydrogenic. Right. So dysplastic and congenital. Right? Dysplastic is where you have the positive. Congenital is where you have like not like the absent facet joint or any like abnormality within the bone. So this is the dysplastic allostomic type. Yeah. And grading, how you know the name of the grading? What grades?
So there is Whitson, Newman, and McNabb classification.
Yeah, that's the one which you said. That is the classification. Yeah. Grading?
Marketing closing classification.
Myerding grading.
Yeah. It may not be that useful, but it is useful in explaining to somebody Myerding grading. It doesn't give us any information about pathology or management options. It tells us how bad this is. Okay, so basically 25%, 50%, 60% are completely gone. So it's, depending on how much it is, it doesn't tell you about what happened, what is the pathology, what do you do. That's not Myerding grading. It's a common one, grade 1, grade 2, what we describe. So we'll see Newman classification, the one which you described before, congenital classification. So this is a 24-year-old man presented with a back pain. You have a grade 1 listhesis. It does have mainly back pain, occasional leg symptoms. So how do you investigate him further?
First, I would like to take a flexion extension views, a dynamic views.
Yeah. So what does it give an idea? So is it moving or not, isn't it? Is it going to be helpful in deciding how you manage them? So there is a positive effect, definitely. And there is instability. So flexion extension is going to add anything further. You probably need to get an MRI scan, isn't it? To assess if there is any disc or any from your nerve root compression. That will give us more information and how bad the disc is. Yeah. So this is the oblique, the Scotty W. So this is the ear of the spider. So that's the pars central atlas here. You can see that there is the break in the pars central atlas. Yeah. It's not like clinically, it's not that useful. Only because it is described, some of them get, but it's not useful for us to decide what to do. Yeah, there's no need to get this X-ray specifically for this because there is. CT scans give an indication of how like confirmation of your past effect. Sometimes also gives how bad the gap is and whether if you are trying to repair them, you can assess the gap. But MRI scan will give us more information about what the disc is and how, is there any compression on the nerve. So if this man comes to you with just back pain, very occasionally neurological symptoms, and you get an MRI scan, what are you looking in the MRI scan for him? So what are the things we are looking at?
We look at the the cartilage complex.
Yeah.
And the nerve root.
Yeah. So here, main important thing is whether the disc is still hydrated, is normal. Yeah. If it is normal, and if the foramen is not that compromised, so main problem is the past effect, which we can address with the repair. If the disc is degenerated, or if there is a foraminal narrowing with the compression of the nerve, then just addressing the past effect may not be sufficient to address the problem, isn't it? So you may not, like, even if you repair the past effect, is not going to be a happy person. So in the MRI scan, what we are looking at is how is the disc, whether the disc is degenerated, and is there any foraminal stenosis, so causing radicular symptoms. If they are there, then you are looking at fusing the whole segment. So take out the disc and stabilize with the pedicle screws and rods. If the disc is well hydrated, that is a young man, 25, the well hydrated disc, and the foraminal height is well maintained, you can repair the past effect using a screw across the past. Yeah. So you can repair different ways of doing it. So this is one way of doing it. Is curved rod across your spinous process and use a pedicle screws and compress the past effect. Other way of doing is to put a screw across the past effect using a buck screw, we call. And if the disc is degenerated, if there is a foraminal stenosis, then it's probably easier to do this way to address the whole problem. Fusion. It's very very quick view of it. Any questions?
Is the rod sitting on the spinous process or in the fist process?
Which one? The rod.
Yeah.
So this is sitting on the spinous process. Basically, what it does is compresses the lamina. So if you see that, so it compresses the defect. We use the pedicle screw. Yeah, that goes around your spinous process and press on the defect. So you open the defect, freshen the bone ends, and put a graft in there, and use the screws on this rod to compress across, so that it will heal.
Okay.
So it will save its disc, and it helps our fusion. So that is in young patients with a normal disc, and there are no foraminal compression or no radicular symptoms and no neural compression. This is a way. Other way of using the lag screw as well, like going across the defect. Or there is another way of using this is to use the screw there and a hook across your lamina, just compress across, and one on this side, one on that side. But everything is to try and compress the defect and achieve union. Any questions?
Hello, sir.
Yeah.
Sir, regarding the dynamic views of X-rays that we take.
Mm-hmm.
So if we suspect a spinal trauma, isn't it better to avoid the dynamic views?
Yeah, so dynamic views are useful if you are doubtful about the stability. Okay. In cervical spine, sometimes you do them in a controlled manner. In lumbar spine or thoracic spine, rarely you need them because they are either it is stable or unstable. So dynamic views for trauma is only in cervical spine. Sometimes you do them and you are doubtful. That also a very controlled way. You go there with a to the radiology department and you hold the head and ask them to do. One thing where we here very commonly we use is the C2 fractures. The elderly population here have a lot of C2 fractures, and we treat them conservatively. Many times when they come back, we do a dynamic view just to see if it is mobile at all, even if it is not united. But if it is stable enough, we sometimes discard the collar, but that is the only dynamic views we do. Otherwise, in a trauma situation, you don't need to do a dynamic views these days because we have CT, MR to decide whether it is stable or unstable. Anything else? Yeah, let's go to the next one. Okay. So, who is going to take this? John C. again. Your name is there. Go on, John C.
Hello. Yeah. This is a plain X-ray lateral view. skeletal mature patient with listhesis of the cervical spine. Of C4 over C5.
Yeah. So listhesis. So what is more likely injury here? Is it degenerative listhesis or injury? What do you think?
It is an injury, sir.
Some other indication. So there is a tube here. In the front.
There is a tube. Yeah.
And there is some going in. So it's more likely to be rotor fractures or like a major injury.
Polytrauma.
Yeah, it's more likely to be trauma. So this is a P4P5 fracture subluxation event. Yeah. So is it unifacet subluxation or bifacet subluxation? Is there any suggestion on the X-rays you can see? Is there any importance of unifacet and bifacet? So both facets dislocated is more likely to be definitely unstable. So you need surgery. If it is unifacet dislocation, sometimes you can't treat them conservatively if there is no neurology. Yeah. So how do you decide on the X-rays? Is there anything you can say? If the displacement is less than 25%, more likely to be unifacet subluxation, but it depends on the CT scan. But more likely to be unifacet subluxation if it is less than 25%. So it is 1 week old injury. He is intubated and ventilated in the ITU. What are the things you're going to? We don't know. It's neurology. CT, MR, what do you get? So we do get a CT to assess the fractures. Basically, look at the facet fractures or any laminar pedicle fractures and assess the bony anatomy. We do get MR to assess the cord. We don't know it's neurology because it's intubated on arrival. So we get a MR to assess this cord. How do you treat them? Usually we go 360-degree fusion, basically go anterior, take the disc out, and stabilize with a cage, and go from back and the screws. So it's front, back, front, or back, front, back. So you have to do in three stages, because you have to reduce the fracture as well. So if you go from the front alone, you may not be able to reduce the facet if it is perched on one. So going from front alone may not be sufficient. Sometimes you can, if you're reduce it, but many times you end up doing three, front, back, and front. Any questions? Okay, this is a simple one. This is Anupam.
Sir, these are the MRIs of lumbar spine, sagittal and axial sections.
So what do you see? So MRI T2 or T1?
It's a T2 image, sir.
So is there anything abnormal you can see?
There is a disc L4, L5 disc bulge, disc protrusion. In the axial section, you can see it is more towards the right.
Yeah. The right paracentral disc prolapse at L4-5. Yeah.
Yes.
So which nerve root get affected in this patient? So if he comes to you, what nerve root symptoms he will be having?
EHL weakness.
So which is that? L4 or L5?
L5.
L5. So L4-5 disc prolapse usually get nerve root of L5. Yeah. But if it is a listhesis, spondylolisthesis of L4-5, you get symptoms at L4. Yeah. So this usually catches the nerve how it is going down. The listhesis usually get in the front, so usually it is if it is L4-5, usually they have L4 symptoms. The disc prolapse is L5. Yeah. So what do you do with this patient? This is a 30-year-old somebody with the symptoms like this going on for the last 3 months. Operate him?
Conservative trial first, sir.
Yeah, how do you do conservative trial? What do you do?
Give a course of steroids and tapering dose.
Yeah, the role of oral steroids is not even in this situation or in any pain situation. So not like nowhere in the Western countries give oral steroids for pain. I think that's probably only us being in India, but nowhere in UK. If you have any pain, they try not to give any steroids. Correct? So what we try to do, given neuropathic medication like gabapentin and pregabalin, those ones are effective, along with analgesia and sometimes anti-inflammatories. What else you can give it to them? You can give a local steroid. Yeah, so epidural, like a transforaminal epidural or a caudal epidural injection. So with a transforaminal, you can catch the L5 nerve root and you can give a local steroid there. Sometimes it is helpful. You give the conservative management for 3 months. It comes back to you, the symptoms are waning off, but is still in pain. So what do you suggest to him? So in essence, what is the natural history of this condition? Is it like how many people will require surgery in this? Do you have any idea? It is not a lot of rich literature on the conservative management, in the sense what happens when you leave them. The literature which we quote many times is very old paper. I forgot his name. So they followed up these disc prolapses and they said 90% of them get better, but it's not very scientific way of looking at it. It was a retrospective trial thing. But the recent one is a sport trial. There is a multi-center trial in America where they looked at what happens to the disc prolapse if you leave them conservatively and operatively. It is like a randomized type of randomized, because they couldn't get both arms they couldn't follow them up for long. But so if you look at the operated and non-operated, at the end of 2 years, both are same. The only advantage the people who had operation early on is that the pain relief is better early on, first 3 months. Yeah. But otherwise, there's no difference between the operative and non-operative. Any questions? So we discussed this. So who's next one? Jerry Gabriel. So what is the diagnosis here? No? No. Anupam?
So this is plain X-ray of the thoracolumbar spine of a skeletally mature patient, showing anterior and posterior osteophytes formation. Changes are suggestive of ankylosing spondylitis.
Okay. So osteophytes. So you see, where do you see the osteophytes here? Like, it's not osteophyte, isn't it? So what is the pathogenesis here, and what happens in Angstpon? You're not seeing any osteophytes coming out here, isn't it? Yeah.
Yes, sir.
So why that happens? Like, this is not a usually see osteophytes in other osteoarthritic conditions, but this is not like that. Why is that? What is the pathogenesis? What happens? Why do they get a bamboo spine? You should be knowing more about this than me.
Autoimmune pathology.
Autoimmune pathology. Okay. So, but usually, what happens to the why they get this changes in the vertebra?
Syndesmophyte formation.
Syndesmophytes. So syndesmophytes is because of pathology.
Annulus fibrosis undergoes calcification, sir.
Yeah. So is it annulus fibrosis which goes under calcification, or is it something else which creates this problem? We need to look at the why do they get things there? Annulus fibrosis doesn't go into the, because they doesn't have any blood supply to that, isn't it? What in the spine? What are the things we operate on these patients? What are the common things we operate on these patients? Apart from your hips. So usually these patients have they have fractures, usually the chance fracture. So fractures, unstable fractures. So anybody coming with Angstpon and injury, you always treat them as unstable patients. Yeah. So the one condition is fracture. Other is they are losing their forward gaze. So their spine is so deformed that they can't look up. They can't look at forward. So their vision is always looking at their feet. So there you probably need to correct your deformity by doing osteotomy surgery. Usually either in lumbar spine or cervical spine, mostly lumbar spine. We take one of the vertebra like a wedge shape and create a lordosis so that they become straighter. It's called the vertical flexion osteotomy. So these are the common things you see in the spinal surgeries in Angstpon.
Kyphotic deformity. Cervical spine fractures.
Yeah. Yeah, those are the two things which you commonly require surgery. The kyphotic deformity causing loss of forward gaze and the fractures. Any fracture, anywhere. Usually they're
Sacroiliitis in hip joint.
Hip operations is. Anybody can take this? Shamsher. What do you see on the X-ray? Is it there?
Shamsir, he's my trainee. He's probably logged on just to make me happy.
Ronak? Shyam. Go on then.
I see a fracture of C2.
Okay. Yeah, start describing the X-ray. X-ray of the cervical spine lateral view.
X-ray of cervical spine lateral view.
Anything what is this called? Open mouth view.
Open mouth view.
Yeah. So we are looking at this open mouth view. What we are looking at? This is C2 and this is C1. Yeah. We are seeing dense and atlas. So if you see the lateral view, you can see that there is a gap here in the C2 in the dense. Yeah. That gap is the fracture of your C2 vertebral, so big fracture or dense fracture. Is it stable or unstable? Medium. Usually they are stable fractures. Only problem with them is whether they heal or not. So this is the type 2 fracture to the dense body. Okay. The fracture is to the body, that is type 3 fracture, they heal well. Or the fracture of the tip of that is type 1 fracture, they are healed well. But this is type 2 fracture where the junction of your body with the dens, they are known to go into non-union. But they're usually stable fractures. So if in elderly patient, which is very common, this fracture is, we treat them non-operatively. Even if it doesn't heal, even if there is a fibrous union, because of low functional demands, we can just leave them as like that with a non-union. The younger patients, we try to fix them, fuse them to the body, go from the back and fix C1 and C2. Any questions there? This is cervical myelopathy discussion. And this is fracture. Nikhil?
Yeah, let's see how it is, because we are a bit late now, isn't it?
Jerry,
you know,
Jerry Gabriel, is it?
Just good.
Is it there?
Yes, sir.
Okay, what is this?
So, MRI of lumbar spine, sagittal view, as well as axial section. So T2
no problem, sir.
weighted image showing intervertebral disc prolapse.
So what you are worried here?
Sorry?
L1, L2, L3 fracture with the myelogram cutoff.
I can't hear properly. So you're worried about, why do you need a myelogram here? I can't hear you properly, Jerry.
L2, L3, L4 fracture with the myelogram cutoff.
I don't think it is a fracture. It is L3, L4, 5 central disc prolapse. Yeah, causing compression on the cardiac vena. So this is potentially a cardiac vena syndrome. Yeah. So if they present to you with this scan and any bladder symptoms, like they're not able to pass urine or they're having incontinence, that is cardiac vena syndrome, or when you examine them, if you see any perianal sensory loss or any perineal sensory loss, more like cardiac vena syndrome. Yeah. So the image alone is not the one which tells you is a cardiac vena. It's a clinical assessment, which is basically your bladder function and bowel function and the perianal sensation. And those are things which you need to look at. Okay. If they come to you like this and there is no pain at all, you don't have to name them as a cardiac vena syndrome. Cardiac vena syndrome is a clinical diagnosis. If this case presented to you as with the bladder symptoms, what do you do?
It's a surgical emergency.
Yeah, it's a surgical emergency. So when do you do the operation? That is the common question. Whether you do it in the middle of the night, or whether you do it next day, or whether as soon as. Before, what we used to think, like a couple of years ago, even when you are going for exam, we used to say, oh, doing next day is probably if it is coming at 10 o'clock in the night, waiting till morning is probably okay. But these days it become like do it as soon as. So whenever you see them with the bladder or bowel symptoms with this type of scan, you take them to theater straight away, because evidence is that sooner you do is better. So as soon as you can. And especially if they have developed bladder symptoms already, there is no guarantee that even after a decompression it is going to improve. But being early, there is evidence that there is a chance it can recover. So the optimum time for surgery, there is no optimum time. These days we are saying that do it as soon as you can. If there is any other problems, take them straight away theater. And anything you want to ask here?
Any quick doubts as it's getting late? Any doubts on this? It's a very important topic.
Okay. The last one, who's going to take this? Vince Wilson.
Extra skeletal mixture patient showing the lumbar spine AP view and a lateral view.
Mm-hmm. Anything abnormal you notice?
Lysis of the pedicles.
There is loss of vertebral height.
Lysis of pedicles.
Loss of vertebral height. Somebody said
L5 level.
Pedicle.
So what do you call that?
Winking owl sign.
Winking owl sign, yeah.
Seen in
So
metastasis.
what is more likely to be?
A metastasis.
Neurological fracture.
So this is a very typical picture of metastatic areas. Damage to the pedicle lymph nodes. Further investigations, what do you do?
MRI.
So MRI and any bloods.
Then for prostate specific antigen.
Benson protein.
Yeah.
Prostate specific antigen.
Yeah. So you do all the screening for your metastatic lesions and colon specific antigen. But from the imaging point of view, CT of abdominal thorax, and the MRI scan of the whole spine. So if it is in one area, don't just do the lumbar spine alone. So just to get the whole spine, is more likely to have multiple metastases. And the treatment, I'm probably not going to discuss now, and it's probably too late. So any questions?
Yes, sir, we're really enjoying. Any questions from PGs? If not, we can slowly wind up.
Prabhakar, it's been a pleasure. Thanks very much once again. I think give a big round of applause to Prabhakar, who's come all the way from UK. We were actually trainees together, so it's good to be good to hear you again. Okay, thanks.
Thank you very much.
Thanks very much from all of the
I hope that is useful.
Okay.
Yes, sir. It was. You have highlighted all the important topics: scoliosis, myelopathy, listhesis, disc prolapse. I think all these questions even come as essay questions for their theory as well.
Yeah. Thanks very much, guys. Thank you.
Thanks very much, bro. Good night. Bye bye. Thanks, guys. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, Srinivas.
Thank you, sir.
Thanks, Srinivas. Bye bye.
Bye, sir. Thank you.